So in the reproductive, yeah.
Yeah. You want a cake stand?
Details other than, this is other than, pregnancy related, so. Without further ado. I just work required, you have to work now. All right. Okay, we're gonna get out of this. Duplication, fine. No, I think he's making. I don't need it, I don't use this. And then we'll. Oh. Okay. Get out of there. Okay. One, I guess. Make it to I think it's the last, exam 3. There was a question about when you don't use androgen agonist type of drugs. Okay. Keep in mind the type of organs, what androgens do. Okay, you've got to go back to your physiology on this and realize that they are going to stimulate. They're going to stimulate, you know, your androgens are your testosterone, etc. They're going to stimulate spermatogenesis. They're going to stimulate the components within the testicles, which is your male gonads, which is where spermatogenesis occurs. It's going to stimulate the prostate gland. Okay, so and testosterone and your androgens are absolutely necessary for bone growth. Okay, in the periphery and, you know, health and well-being of muscles and bones. So, and new tissues. So testosterone, your androgens, they are important hormones for all of those things. Okay. However, when you have testicular cancer, when you have prostate cancer, okay, you're not going to use them, at least not by themselves. Okay, because they're going to stimulate more growth of cancer cells. Okay, so think about it in terms of that. Okay, remember, recall what they do. Okay, so structure and function is here. You're, you know, again, as much as I went over this last semester and how the gonads actually develop in the abdomen at around the L1 level and then descend into the scrotal sac during fetal development, you know, and that's why the innervation is L1, even your cremaster muscle, your crematoric reflex is L1. A lot of people still got that wrong. It may be a concept you'll see next week already. Okay. So again, they develop intra-abdominally, descend. Okay, and they are, so all of the vessels, the blood vessels, the spermatic cord, all of that, okay, it has to descend into the scrotal sac. Why? Because for optimal sperm growth, it needs to be below core body temperature. Okay, at core body temperature, the gonads have the increased risk of malignancy, which is why undescended testicles need to be removed surgically. Okay, down the road. But so the dissension and the whole process of that, okay, there are membranes or connective tissue that envelops the testicles and the cord and everything else. And sometimes when they drop, things can happen. Okay, and yes, fluid can be retained. And that's what we call a hydrocele. Okay. Other complications can develop and or as a result of inappropriate dissension, non-dissension, etc. And realize as well, the, that premasteric reflex and that cremaster muscle, the way it's attached to the scrotum, okay, when it retracts, it not just lifts, but it kind of rotates. And so it can lead to a testicular torsion, which is your surgical emergency. I realize that there are, what each of these structures do. So your cord, the spermatic cord, has arteries, veins, and lymphatics. Okay, so if you get an epididymitis, you're probably gonna have tenderness where that epididymis is, as well as along that spermatic cord, and maybe even up into the groin area, because that's your lymphatic drainage. Okay, and that the reproductive, there is a series of glands, including your Cowper's glands, including your seminal vesicles, including your prostate, each of which produce necessary components for the ejaculate that is the medium in which the sperm are nourished and transported through the reproductive tract, okay, through the urethra, the prostatic urethra, through the penile urethra, out into the environment, okay, and so all of those components have specific functions for the sperm. The sperm, as you know, it's a continuous process. It takes, about 60 or 70 days for the development to occur. The sperm factories are the seminiferous tubules. You have your two different types of cells, and they're your Sertoli cells and your Leydig cells. Okay, each of which responds to different hormones and has specific responsibilities. Okay, the sperm, once developed, will be stored. They, maintain they get their mobility in the maturing epididymis, where they can be stored, so the rest of the specifics about your the different solutions, the different components of the male semen are here. You should probably know those as well. Okay, these are your specific hormones. Okay, which one stimulates what? FSH is all about spermatogenesis, just like it is about oogenesis. And so those are your gametes. And so that's what the FSH stimulates. LH stimulates to testosterone that is produced by the Leydig cells. L and L. Hey, Stephanie. Spermatogenesis, Sertoli cells, S and S. Easy ways to remember it. Okay, and yes, the testosterone is necessary for that. It does provide a negative feedback system, mechanism for your gonadotropic hormones. And so low T is associated with a decrease in libido, et cetera, et cetera. It's also necessary for your secondary sex characteristics, which is why in your hyperandrogenic states in females, you have facial hair, chest hair, the portioning of the voice, the deeper voice, okay, all those things because of hyper androgenism. All right, so what are some of the disorders we talked? So these have to do with the actual descent and or the structures of the male testes and scrotum. The hydrocele is just, it's hydro, it's water in it's essentially a fluid-filled component that develops most of the time. It can be there at birth. It can also be caused by trauma. Okay, and so if it's congenital, it has to do with peritoneal fluid that accumulates as the tunica vaginalis kind of encapsulates that gonad as it descends through the inguinal canal into the scrotal sac. Okay, during fetal development. If it's acquired, it's usually due to an injury, And, infection or a tumor. So make sure if you have one, it's acquired, it wasn't there at birth, it's something new, you pursue those 3 avenues. Okay, if it becomes too large, it can make the scrotum very, very large, it can make the testes, the scrotum itself, very, very heavy. It can become problematic, okay? And so, yes, it can cause, compromise to the blood supply if it gets too large. The spermatocele is actually a cyst. It contains sperm and fluid. It's usually located between the testes and the epididymis. Okay, and it's very specific kind of cystic fluctuant area. The varicocele is your bag of worms, okay? It's dilated veins in the spermatic cord. And more so, we see it on the left side than on the right, and it has to do with the lack of valves in these veins, which prevent the backflow of blood. And so it can affect blood flow as well, if they get too large and it's too much for the return flow. And so that can lead to infertility down the road. The torsion, as I stated, it has to do with that rotation. And as it rotates and it twists on itself because of the action of that master muscle and its attachment, as it contracts, it's gonna lift and twist. And it has that bell and clapper kind of thing. So if you go back and review that, it all depends on the length, etc., which will allow it to twist too much. And if it twists, it can compromise the vascular supply, lead to ischemia and necrosis. So it is a surgical emergency. Okay, and this kind of shows you on the left, it shows you a normal vein system and versus a varicocele. Okay, normal vein and a varicocele. Okay, and so when you have problems with the valves and you get that backflow pressure, it's going to dilate the vein, much like any other kind of varices, okay, or varicose vessels. And that's how you remember it. It's a varicose vessel of the spermatic cord, okay, also known as a varicocele. All right, hydrocele, okay, normal, healthy. And this is the collection of fluid that develops here. And again, these can get fairly large, especially if they're acquired after trauma or tumor, etc. Prostatitis, infections and inflammation. We're going to start with prostatitis. Okay, again, a lot of people got this incorrect. It is an ascending infection typically. Okay, the prostate is, so in a male, we don't usually see UTIs between the ages of 1 and 50. Can happen early on in neonates, but usually between the ages of 1 and 50, we don't see UTIs unless there's some kind of abnormality. Okay, you're more likely to see a urethritis from an STI. Okay, you can see prostatitis, but a lot of times these infections, it has to do with, remember, these are all connected. So you have your prostatic urethra, which your prostate has ducts. If you have a prostatitis or a urethritis, that urethritis, those bugs can ascend the urethra. Okay, it can get into the prostate, it can get into the bladder. The prostate itself, because of its vascular supply, because it isn't a hormone-driven organ, okay, and it has high vascular supply, a prostatitis in a male urinary tract infection is considered a complicated infection. It is not a simple or uncomplicated infection. It is considered complicated. So in your sexually active males, you always have to think STIs first, because that's where the bug's going to come from. Portal of entry. in your older males, males who have had catheters in or who had other procedures done. You know, yes, it could be a UTI, and you've got to think of your typical UTI bugs like E. coli, etc. You can't rule out an STI, but it just kind of shifts your differential as to which organism it is based on patient history and sexual activity level, et cetera. Remember that the normal urination in the male tract, because it is, the male shares the urinary tract with the same reproductive tract, it's the same, okay? That when they urinate, that is the normal flushing mechanism to keep those colony counts down in the distal urethra. Okay. Being uncircumcised is a risk factor for an increase in infections and increase in colonization in that distal urethra, which can then translate to other cystitis, prostatitis, etc. So anything that increases the colony count can shift that spectrum of disease from colonization to infection to then sepsis. Okay. So that's really what you need to know from a pathophysiologic standpoint. Balanitis, again, when we're talking about infections and inflammations, balanitis is typically a fungal infection and caused by Candida albicans, same organism that causes a yeast infection in a female, the most common organism anyway, there are others. And so it involves the glans penis, and yes, it's not considered an STI per se, but it can be transmitted during sexual activity. So yes, your uncircumcised males are more prone to this because of, remember that your yeast like dark, wet, moist places, more moist places, okay? And so with that foreskin covering the glans penis, then it creates the perfect environment for yeast to grow. That foreskin has to be retracted and clean the glans penis and all around it appropriately. And, you know, obviously patients need to be educated on that. So the typical signs and symptoms are very similar to that of a yeast infection in a female: burning, itching, okay? And yes, it can lead to denudation of the skin and maceration of the skin. And it can be pretty bad. And we do treat it with topical antifungals, but good hygiene is the most appropriate response to that. BPH, okay, BPH, we typically see it in older males. It is very, very common. And so it is benign, however, benign in terms of malignancy and metastasis, okay? It's not benign when you have a male who has not been able to urinate in 72 hours and his bladder is descended above the level of his umbilicus and he's got 3 liters of urine and he's about ready to pop, okay? And he's developing hydronephrosis because of backflow, okay? Obstructive uropathy. So, you know, not necessarily a good thing. And not benign in those terms. Okay, just benign in terms of metastasis and malignancy. So usually the patho on this has to do with hyperplasia of the prostatic tissue, okay, which then can lead to nodule formation around the urethra and compression, okay, of that prostatic urethra to the point where it leads to, you know, inability to, it will compress that prostatic urethra to the point where the male cannot void. Okay, and so it has to do with imbalance between estrogen and testosterone, that occurs as patients age. Right? And yes, if the bladder's not flushing, you're not getting a good forceful stream, you're dribbling. Okay, all the signs and symptoms that you know are associated with BPH, okay, you're not getting that mechanical flush to decrease the colony count in the distal urethra, allowing those bacteria to ascend, leading to frequent infections. And again, all the other things. It can lead to kidney damage, so that's obstructive nephropathy. Okay. Prostate cancer, most of these are going to be adenocarcinomas, and they typically occur in men over the age of 50. Okay, and you know, again, cancer, there can be a genetic predisposition, but as you know, there are multiple factors that can lead to your typical cancers. Okay, so it usually the cancer itself rises from the tissue near the surface of the gland. So, you know, and that Gleason scale is what really kind of determines the type, the degree of how aggressive that tumor is. Okay, and how extensive it is. How extensive it is, if it's outside the capsule, all that kind of stuff. So, and these are very often very androgen dependent tumors, which is why we can treat them and we can block some of the stimulation with them, but we don't want to completely shut down other parts. So go back to your lecture on that with Dr. Noel and what drug you add. Okay. Realize that, again, as I said earlier, the prostate is a very vascular organ. And so depending on the aggressiveness of the tumor, it can metastasize. And when it does, it often will metastasize to the bone, especially in the pelvis, the spine, the hips. And it can lead to pathologic fractures. It can also invade your local lymph nodes. That's most common. All right. Testicular cancer. Again, these are gonads, so equate them to the ovaries. Okay, so they're like the ovaries. So most of these are going to be germ cell tumors. Okay. It is the most common solid tumor in men. And you know, if patients have cryptorchidism, then where you have that undescended testes, then that's going to increase the risk of this developing. So, you know, when we talk about germ cell tumors, you got to think of the different types of cells that are in the testes. And the most common cells, you know, you have your, you know, obviously you have your Sertoli, your Leydig cells, and you have all these support cells, et cetera, et cetera. And so different ones are going to, you know, be a little bit more aggressive than others. Some of them will secrete HCG and some of them will secrete AFP. Those are your tumor markers for testicular cancer. This is one of the times where you would order an HCG on a male. Okay. Some of these tumors will spread pretty aggressively, and other ones will remain relatively localized. Obviously, this is, if you catch it early and it's local, this is one of the most treatable cancers because you can remove the testicle in which the tumor is, and the patient still has the other testicle, and you can completely remove the tumor without, you know, significant adverse effects. Where does it spread? If it's spread, it's going to follow that loose lymphatic channels. Okay, and so you think about your iliac nodes, your para-aortic lymph nodes in that lower section, then it will go even higher into even the mediastinal or supraclavicular nodes. Okay, lungs, liver, bone, brain, all also possible. Okay. And so, that's really it for the male. So those are the things you need to know for the male for this final exam. Questions? I know I kind of blew through it. But it's, you've heard it all before. Okay, it's a good review. The female reproductive system, a little bit different, okay? 3 orifices, in the genital area, very proximal to each other. And the GU tract has its own, you know, entrance. And so they are separate. Okay. You know what structures are there, okay? You've learned all the different structures. So this is all review. Realize that your vaginal pH is typically mildly acidic, around 5.5, okay? And that helps to protect against infections. And so it's not, you know, seriously acidic, like, you know, it's not gonna host acidophile bacteria. But when we alter that pH, then it can lead to overgrowth of other organisms, okay? That balance is very, very important. Your glands, as you know, you have the Skene's glands, you have your Bartholin glands, and so you can see they have their specific function, much like the you know, the seminiferous, the seminal vesicles, the vulvar glands, and the prostate in the male. Like, each of these structures, cervix is the neck of the uterus, right? It is truly part of the uterus. That external os is the opening to the upper tract. It does have those columnar epithelial cells with a transformation zone. That's where most of your cervical cancers are going to occur. All of these structures are very hormone dependent. They are very revascular. The uterus itself is a very small kind of muscular, it's a very muscular organ, okay, about the size of your fist, maybe smaller, okay, that sits in the pelvis, okay, in the true pelvis. It's suspended with ligaments. It allows the, as you know, it allows the embryo to grow into a fetus, and you know, it allows the uterus to ascend and create more space for the growth of the baby, okay? The wall, the muscles itself are what is the contraction of the uterus to pass that baby through the birth canal. There are 3 functional layers. Well, there are 3 layers. So with the perimetrium, the myometrium, and the endometrium is the functional layer, and that's where your blastocyst is going to embed for growth and development of the placenta. Okay, the myometrium is the muscle part, the perimetrium is just the outside covering. Your tubes are important because that's where fertilization occurs, typically in the ampulla of the fallopian tubes. Tubal patency is important to prevent ectopic pregnancies and or ensure fertility. The ovaries are obviously the gonads for the female, and your breasts are, they do play a significant role in reproduction, and they do respond to your hormonal changes. So, you know, and of course, lactation down the road. So, you know the different phases of the menstrual cycle. Okay, so those are important. Good time to review those. Okay, all this is hormonally driven. Okay, and yeah, last week you were talking about contraception, and remember that when you have estrogen and progesterone together, it is inhibitory of GnRH at the level of the hypothalamus. Okay, so So that is part of our birth control and why that birth control works. Okay, so, and progesterone alone is also inhibitory, but estrogen and progesterone alone are inhibitory. You know, your different phases of menses. Okay, and let's see. FSH, as I said, much like in the male, FSH is what stimulates the egg to develop, where your LH is what releases the egg. Right? It luteinizes, it opens, your corpus luteum becomes the major producer of your progesterone, some estrogen following ovulation in order to maintain the endometrium for implantation. If implantation doesn't develop, then the corpus luteum becomes a corpus albicans, you stop producing that progesterone, and the endometrium sloughs, and that's what we call menses. Okay? And we do this every month. Okay, very simple. Okay, structural abnormalities of the uterus. There are, you know, the normal position of the uterus is anteverted and anteflex. So it's anterior, it lies kind of over top of the bladder. So, but it's, yeah, anteflexed, okay? There are people who have retroverted, retroflexed uteri. So instead of being anterior, it's posterior. There are some studies that show that this is, this increases the risk of developing endometriosis. Okay, so those who have retroverted, retroflexed uteri, that may increase the risk of developing endometriosis. And just because of positioning. And again, they think it has to do with migration of the endometrial tissue. Instead of draining, it can actually go retrograde and go into the tubes, out the fallopian tubes, or into the peritoneal cavity, etc. So sometimes if women have retroflexed uteri, then it can lead to significant back pain, especially during menses. And it can lead to painful intercourse. And it doesn't have to mean that they have an infection, but it can be painful. So as we age and we lose collagen, all of this is maintained, suspended. All of these structures in the female pelvis are suspended by muscles and ligaments. Okay, and so with multiple childbirths, the levator ani muscle in the lower pelvis can become more lax, and that can allow some of these structures to drop. So you can hear things like, yeah, my bladder dropped, now I leak. It is a source of incontinence. It's a source of a cystocele. Cystocele, again, anatomically, cystocele is your bladder. Anatomically, it is anterior to the vagina, and it is anterior and inferior to a normally placed uterus. So if that bladder drops down, it's going to bulge into the anterior portion of that vagina. Okay. And the degree of bulge can be significant. And so we often try to strengthen those muscles to try support. And there are other means of supporting, but sometimes it ends up being surgical. Okay, a rectocele, again, your rectum is posterior to the vagina. And so if your rectum drops or prolapses, it can actually then bulge into the posterior wall of the vagina. And so it can lead to problems there as well. The uterus itself can even prolapse, and there are different degrees of uterine prolapse. Probably covered some of those complications today in FinMed. Or maybe it'll be Thursday. Cystoceles, rectoceles, uterine prolapse. Yes, no?
We did it in gynecology.
Okay, you did back in the
Last
fall.
semester.
Okay. All right. So those things can happen as a result of these lax muscles stretching out, loss of collagen as we age, all of those can play a role. Okay. Again, this just this gives you an idea, diagrammatically of how all these occur. Okay, so normal position is for the uterus to be anteverted and anteflexed. So anteverted, anterior, your bladder sits here, the rectum sits here. So if the bladder drops, it's gonna compress the anterior part of the vagina. Okay, so the bladder here, if it drops, it's gonna compress the anterior part. The rectocele will the end, if the rectum kind of prolapses or drops down, it's gonna push in on the posterior wall of the vagina. Okay. And then, of course, the uterus itself, if it drops down, there are different grades of that. So I've seen a complete uterine prolapse that came into the ER and like the whole uterus, like pretty much outside. Yeah, it's pretty amazing. I've seen rectal prolapse too, where the rectum actually exits out. And so, again, surgical repairs. Questions? Or you just do it, like, it is horrible. All right. What women have to go through. All right, your menstrual disorders. Yeah, I'm sorry, there's just no time in the fall, or there hasn't been time in the fall to include all this stuff, so it's like, okay, let's finish it off. Amenorrhea. Okay, there's primary and secondary. Okay. Primary. When the female never had a period, right? It's not occurred. And so there are several reasons why this can occur, right? But, you know, that's your basic, have you ever had a period? And there are often clues. What from a clinical perspective, since we're doing this, what's your biggest clinical clue, that someone's never had a period? Tanner stages, excellent. Okay, so you're gonna look at your Tanner stages. Okay, if there's no evidence of thelarchy, what's thelarchy? Breast development. Okay, if there's no evidence of thelarchy, what does that tell you? What causes breast development? What hormone? Estrogen. Estrogen, okay? So where does estrogen come from? In general. The ovary, okay? The ovary. So if your ovary is not producing estrogen, period, you're not gonna have a period. Okay, it's not responding to FSH. Okay, it's either not responding to FSH, or there is no FSH, or there is no ovary. Those are your options. So you start with that. If the patient has breasts, then you kind of have to go to the next stage. You have these symptoms of having a menstrual cycle. Because then it could be an imperforate hymen. It could be Müllerian abnormalities, meaning that they either do or don't have a uterus. And so you kind of have to go from there. Okay. Otherwise, you're looking at karyotype testing and or you can do FSH levels and look at your prolactin levels, things like that. But if you gotta look, you might have to look at the pituitary to see if there's a pituitary problem. Okay, so those are your big issues there. Secondary is, number one cause of secondary amenorrhea is pregnancy. Yes, music to my ears. Okay, So they've already had at least one menstrual cycle and, aren't having any more. Okay, so pregnancy is the number one cause, but we have to look at other things as well, and it's a much broader, possibility, but that number one cause is always pregnancy, and so you've got to rule that out. Does someone have to have their first menstrual cycle to be pregnant, to get pregnant?
No.
No, because they could get pregnant on the very first time they ovulated. All right, very good, so. Dysmenorrhea. Okay, dysmenorrhea is painful periods. That's all it is. Make sure when you do your write-ups for me, whoever's gonna be in women's health, at least I've been doing all the OBGYN breakouts and write-ups and everything else. That's been my little domain. In a year or two. Dysmenorrhea. Make sure you use the proper terms. And not what the patient complains of, but in your descriptors, make sure you use all the right terms, right? You know them now. So primary, this is typically when, as soon as ovulation commences, and it has to do with excessive prostaglandins, which increase, they're vasodilatory. So they're gonna increase endometrial shedding, increase edema, increase cramping, and uterine contractions. And it can lead, and all of that causes a lot of pain for patients. Secondary causes would be things that, you've acquired, so, endometriosis, PID, polyps, tumors, things like that. Okay, a word about endometriosis. We talked about this a little bit last week with respect to infertility and more so with ectopic pregnancies. But it is endometrial tissue anywhere outside the uterus, and realize it truly can kind of pretty much be anywhere. And so pathogenesis, again, a lot of this is theoretical, but we know that the endometrium, this endometrial tissue, that wherever it is, it's still responding to hormones that are being disseminated throughout the body through the bloodstream. And so it's going to respond to the same kind of cyclic increases in FSH and LH and progesterone and estrogen that our uterus does. And it's going to shed the same way. And so it will leave at the end of the cycle, okay? And so it's gonna go through that whole cycle time and time and time and time again. Blood outside in any other cavity outside of the blood vessels is an irritant. It creates inflammation, and so it's gonna cause inflammatory changes. In the peritoneal cavity, the abdomen, the pelvis, it's going to lead to adhesions. Okay, and so it's gonna lead to scar tissue formation. And these organs, including the bowel, can become very densely adhesed together. It can lead to internal hernias. It can lead to bowel obstructions. It can lead to all kinds of problems. It can lead to scarred fallopian tubes and infertility. It can lead to ectopic pregnancies. Okay, and so all of that is a result of this entire process and the fact that this is blood, dying blood cells that lice release their insides, create an inflammatory response and the rest. So these adhesions can actually, they can occur anywhere, and they can make anything and all of this, including intercourse, very, very painful for patients. Okay. And yes, from the belief is that the endometrial tissue can actually migrate up the tubes, which having a retroflex, retrograde, retrograde, retroflexed uterus, increases the likelihood of this occurring as opposed to being antegrade and anteflex. Right, and so, and it can even spread if it, like endometrial cells get absorbed through the lymphatics, they can actually spread to different parts of the body and be transplanted. Okay, and it can even occur during C-sections as well. So someone may have a normal first pregnancy, have a C-section, and then develop endometriosis after that C-section. Fascinating, isn't it? All right, so female infections and inflammation. So we're gonna talk, we have vaginitis, cervicitis, salmongitis, urethritis, oophoриtis, and mastitis. Okay, so candidiasis, as you know, we talked about that, much like balanitis in a male, this is a superficial yeast infection involving often the introitus or the vulvovaginal area. It does not cause cervicitis per se, it causes a vaginitis or a vulvovaginitis. Okay, and so it's often due to changes in the pH of the mucosal fluids. Often after antibiotics, we wipe out normal flora, we lose that balance, excessive douching, wearing clothes that keep things wet and moist, especially in the summertime. Young girls will often get yeast infections if they've been in swimsuits all day. And it happens as a result of just fungi liking dark, warm, moist areas to grow. So it doesn't have to be sexually transmitted, but it can be, although it's not considered an STI. All right, and so a lot of things, we see it in diabetics sometimes. People who become diabetic, they may have frequent or recurring yeast infections or vulvovaginitis, candida vulvovaginitis, and it has to do with the increase in glucose in those fluids, which is going to feed the fungi. All right. All right, PID, this, again, pelvic inflammatory disease, is an upper reproductive tract infection, okay? Often it isn't, it's typically an ascending infection, much like prostatitis in a male. This is what happens in females, and oftentimes when the os opens during menses, to allow the endometrial slough to descend, bacteria can ascend. And when bacteria ascend, okay, they can get into that upper reproductive tract and they can infect the tubes. It can actually get into the peritoneal cavity and it can lead to that Fitzhugh-Curtis syndrome. Right? It's inflammation that occurs within and leading to adhesions and dense adhesions and in the peritoneal cavity, often extending from the tubes, from the fimbriae, and the ovary all the way to the liver, okay? And so the cervix can be, it often starts with the cervix, it can lead to an endometritis, it can lead to salpingitis, oophoриtis, and even like I said, Fitzhugh-Curtis, where it involves the peritoneal cavity, okay? And so these can be complicated by abscesses in the tubes. Okay, it can be complicated by peritonitis. It can lead to infertility because of scarring in the tubes and loss of normal fallopian tube function and those little fimbriae, okay, that are supposed to get the egg and the fertilized egg down the tube into the uterus. If they're all scarred down, they can't function. And so you're more likely to have an ectopic pregnancy because you're not getting that current to get the egg down into the uterus. Okay. Again, as the cuff is, yeah, it starts low and usually is an ascending infection. Okay, these can lead to sepsis and septic shock. Most commonly, it's caused by an STI, but it doesn't have to be. It can be a mixed infection. You can have anaerobes, you can have gram-negative rods. It is important in your histories, et cetera, to find out what kind of intercourse your patient participates in, if there's any anal intercourse, and if they go from anal to the vaginal penetration, that's going to increase your risk for your coliform bacteria, causing these tubo-ovarian abscesses. Okay, so, you know, other things, IUDs, instrumentation, and, you know, those can also lead to PID. Okay, when you do have an IUD, I mean, again, they've changed the IUD structures some. At once upon a time, they had IUDs that there was excessive risk of developing PID because of the design of the strings that attach to the IUD that kind of hang out through the cervical os. And so they would essentially wick up, act like a wick and allow the bacteria to ascend. They've changed the formulation of those strings so that it doesn't have that same kind of adherence that they did in the past. So much safer now than they used to be. All right, these do often require significant PID. With tubo-ovarian abscesses often involves hospitalization, IV antibiotics, et cetera, because of the risk of the patients becoming septic and or rupturing. All right, time for a break. Get your blood flowing again. Leiomyomas during one surgery from one uterus. Yes, over 100. And that is reality for some people. Okay, they are very estrogen, progesterone, hormonally sensitive. We see them develop during the reproductive years. And they do shrink and degenerate after menopause. Okay, without that hormonal stimulation, they will shrink and kind of go away on their own. Sometimes when they degenerate and they lose their vascular supply, what do you think happens? You're going to have ischemia and necrosis, and it becomes very painful. And yes, these can be painful. Okay. They often will come in multiples. Some of these tumors can be quite large. So when you hear these stories about, yeah, they removed this 80-pound tumor from this woman's pelvis, you know, it was probably a huge leiomyoma. Okay? And I've seen some huge ones. And, you know, they, when they get that big, obviously they can distort the normal anatomy of the uterus. It can affect the ability to get pregnant. It can often lead to heavy vaginal bleeding, menstrual bleeding. It can affect it affects a lot of things. Okay. And so, yeah, sometimes you can palpate them, especially during your pelvic exam, you can clearly palpate them and you can feel these very firm, hard, enlarged masses. Okay. Most of these are benign. There is a small percentage, I don't even know the percent, but it's really small, like 1% will undergo malignant transformation. But that is a potential for the majority of them. They're benign and they go away after menopause. So, you know, one of the questions that I know you've been asked in the past is, what's the #1 cause of postmenopausal vaginal bleeding?
Endometrial cancer.
Endometrial cancer. It's not gonna be endometriosis. Because it's postmenopausal. You no longer have these implants, you don't have that hormonal stimulation. So the implants aren't gonna bleed, you're not gonna have endometriosis, nor are you gonna, it's typically not thyroid related either. Because these degenerate and go away after menopause. Where does vaginal bleeding come from? It comes from the endometrial proliferation and sloughing. So think about it in terms of what you know. And so if that's where the bleeding comes from, number one cause after menopause is gonna be some type of an abnormal endometrial proliferation, aka cancer. Endometrial hyperplasia, endometrial cancer. You gotta rule out endometrial cancer. Does that make sense to you all now? I mean, think of it in those terms. Okay, yes, these tumors can get pretty big. They can push on the bladder. They can lead to urinary frequency. They can push on the rectum, depending on the location now, and it can lead to constipation and problems with patients' bowel movements. They can feel like they have a really heavy pelvis or abdomen and just feel bloated all the time. Yeah, it's because there's a big old muscular tumor in there. Okay, and this you're probably not going to be able to appreciate, but this would be an ultrasound, and they can actually identify these on ultrasound. So, you don't have to worry about that for this class, but just kind of interesting.
I guess I'll Leo my
All
problem.
right, some benign ovarian cysts and PCOS. Okay, so ovarian cysts, most ovarian cysts are functional cysts. And you watched the video last week. Okay, and you saw the little cyst developing, and then you saw the egg pop out, and that's what essentially happened. So at any point in the menstrual cycle, you have multiple eggs developing in your ovaries, okay? And so they're gonna be at various stages of proliferation. And so this is due to normal hormonally responsive follicles. They're called follicular cysts. When they rupture, the egg comes out. And yes, there's a little bit of fluid. Sometimes they may halt in their development. Okay, and they'll hang out and just fill up with fluid, especially if the egg doesn't continue to grow. Remember, not all eggs will be ovulated. And some of them will go into become atretic. So you will have these sometimes functional follicular cysts, and that's just normal part of the cycle. Okay, some of them can get large enough to cause problems. Sometimes they can hemorrhage. Sometimes they can just bust and leak a lot of fluid. And yeah, that can be. And if they get big enough, the weight of them, okay, can actually lead to an ovarian torsion. One of the year twos presented a case last week of a woman who had a teratoma that led to an ovarian torsion. Fascinating, cool case to have been on, you know. So they had to take her to the OR, and you know, and there was no teeth in it, but there was a lot of hair, and it was pretty interesting, but they were able to save the ovary because they got her to the OR. So cool, it's interesting from an academic standpoint, but realize these things are kind of suspended out there, okay? Anything that's gonna weigh them down and affect them can get them to twist, okay, on their blood supply, which is by definition an ovarian torsion. Okay. PCOS, on the other hand, These are, PCOS is specifically a hyperandrogenic state. It's one of your hyperandrogenic states where the androgens take over. So you have all these follicles that start to get stimulated to ovulate, but then at some point during that process, they become hyperandrogenic, so they don't ovulate. And so you end up with this series of cystic structures in the periphery of the ovary. Okay, because they got to a certain point, but never quite ovulated because the androgens took over. And so, yeah, most of the time these are, again, and the androgens, you know, kind of overshadow the effect of LH and FSH. Could it be a problem with the pituitary and hypothalamus? Potentially, but most of the time, these women often will have the horse or boys, they'll have menstrual abnormalities, they'll have some, you know, facial hair or other, you know, evidence of increased androgen sensitivity. And so that's why you have all these, you know, and they often have infertility issues. They also have acne. Again, the excess testosterone, the excess in the androgens. Fibrocystic breast disease. Okay, these are, you know, it's benign. Okay, it is benign breast masses. And these are often very, very responsible to fluctuating hormonal levels, especially estrogen, since estrogen is what promotes the development of breast tissue. Okay, and so, you know, in this, some of the connective tissue within the breast becomes replaced by dense, much more dense fibrous connective tissue. And it can be in kind of this lumpy pattern. Okay, and so it has to do with some of the fluid in the breast that increases during the secretory phase of the menstrual cycle. And it accumulates in cysts that are bound within this fibrous tissue and it can't escape. Okay, so you can have fibrous cysts, you can have fibrotic changes. And so this cyst can become, they can enlarge and decrease depending on time of the cycle. And there are 3 categories and that are really based on the risk of developing cancer later on. The non-proliferative, the proliferative, and the proliferative with atypical cells. Okay, so, you know, when you start seeing atypical cells, you've got to think of dysplasia and the potential for malignant transformation. So your non-proliferative, they're going to be your smaller, you know, microcysts and fibroadenomas. The more proliferative lesions is when you're going to have, it's proliferative, you think hyperplasia, and that is, you know, there's family history, this tends to be increased. And then again, anytime you have atypical cells, that's when you're gonna run, you know, you be a little bit more responsive and cautious looking for cancer and doing cancer screenings. Breast cancer itself, you know, clearly malignant. You know, the most common location is up in the tail of Spence, in that upper outer portion, that upper outer quadrant. And most of these arise from the ductal epithelium. And so a lot of them are going to be ductal carcinomas. Okay, and because of the location, okay, with these, the ducts, et cetera, with all of the connective tissue that is in the breasts, okay, you know, as the tumor grows, it can adhere to other structures, including the suspensory ligaments that are attached to the surface of the skin, which can lead to some of the dimpling effects that you see. It can, and it can, because of the, again, vascular nature as well as the lymphatic structure there that mimics or kind of mirrors or parallels the vascular structures, you know, you're gonna get there's a lot of lymph nodes in the area. And so the cancer will metastasize first to the lymph nodes, then to other areas, other structures, once it gets into the bloodstream, including the lung, the brain, the bone and liver. As far as the cancer designation, it's usually based on differentiation, with the less differentiated being more primordial, and that's gonna be your more aggressive tumors and more prone to metastasis, less likely to follow the rules. Right? Whether they have estrogen or progesterone receptors, that's all in the histologic testing. That's gonna be a major factor in the management of these tumors. Okay, so obviously we know that the BRCA1 and BRCA2 genes are strongly associated with both breast cancer as well as ovarian cancers, any kind of female, essentially your female reproductive cancers. And risk factors include exposure to high levels of hormones, especially having early menarche or late menopause. So the longer that the breasts are exposed to high estrogen levels, that's going to increase the risk. Not having children and then delaying first pregnancy also associated. And these are just, you know, obviously retrospective studies. Exogenous estrogen use, so it can be a cause. If you have atypical cells with the fibrocystic disease, obviously that's going, you know, we just said that is a risk factor. Uterine carcinoma, other breast cancer, you know, having it in the other breast, we have it in one, increased likelihood of getting it in the other one. And any kind of exposure to chest radiation at a very young age. So some of your other risk factors, pretty common across the board for most cancers. Okay, you know the signs and symptoms, you know how to diagnose it, and you know how to treat it. Essentially, it's going to be patient dependent. Okay. All right, other cancers, cervical cancer. Again, very hormonally responsive tissue. That's what we screen for with Pap smear, and we look for that dysplasia involving, especially that junction, that transformation zone between the columnar epithelial cells and the squamous cells in the external os. And so, again, it's graded based on the degree of dysplasia as well as differentiation. And yes, it will spread. Very vascular, structure is very hormonally dependent. So lymphatics in the region, and there are strong links to both herpes virus 2 as well as HPV and certain strains of your human papillomaviruses. So two viruses associated with it. Okay. Uterine cancer, most of the time we see uterine cancer, it's in patients over the age of 40. Most commonly, common age range is between 55 and 65. Again, the uterine cancer, it's either connective tissue or muscle. So your leiomyosarcomas. Okay. And again, because of the vascular nature, these have a high incidence of metastasis early, and they can typically metastasize to the lungs. Most of these are, most of your uterine cancers are the majority of them are adenocarcinomas because of the glandular nature of the tissue and specialized epithelium. So, let's see. When, just FYI, when you're prescribing like post-menopausal treatment, if a woman has a uterus, you never want to prescribe estrogen without the progesterone. Okay. And so if the woman has, because of the risk of developing this endometrial hyperplasia. Ovarian tumors, you know, similar to testicular tumors, and germ cells, often germ cell origin. This is a silent tumor. And because it's kind of like hanging out there in the pelvis, you know, just kind of suspended on these different ligaments, you know, and because they're constantly shedding cells, it tends to metastasize very early, and before the patient ever has symptoms of pain or anything else. And so majority of your patients with ovarian cancer are often diagnosed late because of this fact. And it's usually after metastasis has occurred. And the metastasis is often involving other pelvic and or abdominal peritoneal structures. They can present with, you know, your general kind of, I just don't feel good, you know, just bloating, abdominal bloating, malaise, you know, anorexia, those kinds of more general findings, or they can have a bowel obstruction. So, yes. So, right. So, we don't really have any reliable screening tools right now. We really don't. And so I think there's some that are in development, but nothing right now. So we don't have any really reliable screening tools for these, unfortunately. All right, infertility. Realize that infertility can be caused by both sides, male or female, or combination of both. Okay. By definition, infertility is defined as 1 year of unprotected sex, trying frequently to have a baby and not being able to. 3 months of trying or sporadic trying over the course of the year does not qualify as infertility. Okay. In the male, you look at the sperm or semen. Okay, so you gotta do both sperm and semen analysis. You gotta look at structural abnormalities. So anything in the process, if you don't have enough fructose in the seminal fluid, if you don't have enough, if they don't develop motility, they have poor motility, there's a problem with, you know, little swimmers. If there's a problem with scarring within the male reproductive tract and the swimmers can't exit from previous infections, et cetera, or even trauma, all of that plays a role. Right, on the female side, you have structural abnormalities. Right, as we've already talked about, all the things that can lead to infertility. You can have hormonal problems. You can have hyperandrogenic states, and even age with gonadal dysgenesis that occurs. You know, once a woman starts losing all the eggs she was ever born with, and as you get towards the ends of those, you know, and they're less responsive to hormonal therapy, they may not ovulate regularly and kind of run out of eggs. And so, and we don't know when that is, and every woman is different. Okay, average age of menopause is 52. So, plus we talked about infections and scarring and other things structurally that can affect the female reproductive tract. All right, STIs. There has been and continues to be an overall increase in the number of chlamydia infections. Right. It is the silent, it's kind of silent until it's silent in females until it gets into the upper reproductive tract a lot of times. Okay, more times than not. Okay, and so a woman can be a carrier, not actually have overt signs and symptoms, and continue to spread the infection. Because the cervix really doesn't have any pain receptors. Okay, not gonna feel the pain of cervicitis. Not gonna feel it. Okay, and so, it's not until it gets into the upper reproductive tract where they have PID that they start to have the, signs and symptoms of pain and, pelvic pain, etc. Okay, so it is, it will cause a male urethritis. And, until we develop that testing and the nucleic acid modification, being able to do these quick screens, it's been more difficult to, culture because of, it's an atypical bacteria that requires cell culture to grow. So, in the male, it causes an NGU, non-gonococcal urethritis, often with clear discharge, but it could be more purulent or even whitish color. But, unprotected sex, and is the spreader of this wonderful disease. And so, often it's spread along with gonorrhea as well as other STIs. And so, current treatment, as you know, is to treat for both GC and chlamydia. One of the year twos just presented a case, that they saw in clinic in the write-up, and it was a prenatal evaluation. The partners came in for the 18-week checkup, and they did their routine screenings, and the woman came back positive for chlamydia. And according to the student who presented the case, who just wanted to leave the room and not deal with it. Yeah. And the guy sitting there on his phone going. Okay. But honestly, in this day and age, it can be either, so. Don't be surprised. Don't be surprised.
What?
Gonorrhea, the gonococcal, gram-negative diclococci,
I think so, yeah.
and
So sad.
it actually has pili to attach to the epithelial cells. And so this will actually form a purulent exudate. It does get intracellular within the polymorphonuclear cells that are drawn to the area because of its, its antigens on the outside and being recognized. So the PMNs will engulf it, but it doesn't kill it. And so you will see these, they'll call the cervicitis. They can ascend, as you know, become very, very resistant, multi-drug resistant. And so in males, this causes a typical purulent discharge, often called the drip, or called the drip. They used to call it clap back in the day. Don't ask me, I don't know. I'm just saying, you'll hear it have different terms, right? But anyway, it can also cause both of these organisms, chlamydia and GC, can cause a urethritis in a female. And so women who have had a hysterectomy can, if you're suspicious because of the columnar epithelial cells, you actually need to do a urethral swab as opposed to a vaginal swab. Okay, because the chlamydia has a specific predilection for the columnar epithelial cells. The, GC will cause pharyngeal and rectal infections. And so important, and you'll see the conjunctivitis as well. Syphilis. I don't know what to tell you about syphilis. You know, it's out there. It is really, really out there. And you have a patient who's 70-year-old, male or female, who presents with an unusual atypical rash. Syphilis in Baltimore City better be on your differential. Okay, seriously. It is out there, and we're seeing more and more cases of congenital syphilis, which is horrible. And so, welcome to syphilis capital of the whole United States, right here in Baltimore. You know, your primary, secondary, latent, and tertiary. Okay, it is caused by T. pallidum. It is a spirochete. It is anaerobic. This is a painless chancre. Okay. Some people call it canker sore. It's a chancre. Herpes is painful chancre. Haemophilus ducreyi or chancroid is also tends to be more painful. Okay, there is a difference between chancroid versus herpes. Herpes, you get vesicles that then ulcerate, whereas Haemophilus ducreyi, you don't get those vesicles. Okay, and so, yes, you can have all these different stages, and it just has to do with where the infection is. Okay, so herpes, HSV1 or HSV2, again, sexually transmissible. It used to be once upon a time, HSV1 was for oral and HSV2 for genital. And now it doesn't matter, you can have either or. And, but painful chancre, right? With often starts as a vesicle that then ulcerates. It's a shallow ulceration that tends to be quite painful because it inflames the nerve roots where it likes to hang out in the dorsal root gland. Okay, okay. Some patients can have systemic symptoms like these. Okay, also sexually transmissible. Viral shedding continues even after the acute chancre and the vesicles have healed. So patients who have HSV, just because they don't have an active lesion doesn't mean that they can't shed virus. Okay, another gift that keeps on giving. Genital warts. Okay, oh, and so you will hear the term condyloma acuminata versus condyloma lata.
I just hear Hakuna Matata every time.
Acuminata, no, it's not quite that, no. It's far from Hakuna Matata.
I'm more worried.
It is very far from Hakuna. So condyloma lata is associated with syphilis, whereas
Well, now you're fucking
condyloma
with me.
acuminata is associated with HPV. Okay. Condyloma. Acuminata, it accumulates. So this is when you get these big cauliflower lesions of herpes, HPV. So it's all HPV, and like you just get these, it's like a massive mountain of warts. Okay, so they accumulate. Okay. And again, it's a virus that infects those keratinocytes. It can utilize that. It utilize the genetic code to continue to produce and continue to proliferate these keratinocytes so that they continue to accumulate, okay? And so, and when you get that kind of out of control breeding of new cells, you run the risk of, malignant transformation. And as you've seen with, and we talked about that with viruses. All right. Now, here's my review. All right, your reproductive system in men and women. Okay, again, keep in mind, you have internal and external organs, okay, that work together along the complex hormonal network, okay? It's all about procreation. Okay? Any disorder in any of these areas, hormonally and or structurally, can lead to infertility, okay? You have reproductive disorders. You have fibroadenomas that can occur. You have endometriosis. We talked about what it is. You have a leiomyoma and fibroids, okay? Which are typically benign. Very small percentage will go into malignant transformation. Your pelvic organ prolapse is due to weakness in those pelvic floor muscles. And multiple pregnancies, things that are gonna stretch it, are going, are going to increase the probability of that. Your PCOS, a hyperandrogenic stage, which leads to, a halting of primary or your ovarian follicles from maturing and releasing the egg. So you end up with a collection or your string of pearls on the ultrasound, okay, of these cysts around the surface of the ovary. BPH is hyperplasia, not hypertrophy, just like the name. And it's considered benign, however, it's not always benign. Cervical cancer. Talked about that, involves the transformation zone. Can be stimulated by chronic infection because chronic inflammation leads to malignant transformation. It can be due to specific viruses like HPV. It can be due to other viruses like HSV. Okay. Endometrial and uterine cancer. Often you got to think about hormonal stimulation post-menopausal, and bleeding is often your key symptom. Ovarian cancer tends to be silent because of its location or it has very benign presentations because of the seeding of those cells into the peritoneal cavity and leading to other signs and symptoms. Prostate cancer, common in men over 60, 50, and they can still produce semen and they can still nourish the sperm. And so realize that, again, this is very androgen sensitive tissue. So cancer, testicular cancer, painless sperm mass, common in younger males, STIs obviously lead to complications down the road. All right. So low levels of estrogen and progesterone stimulate the hypothalamus to secrete which of the following? Low levels, estrogen and progesterone. Low levels, estrogen and progesterone stimulate the hypothalamus. How many say LH? How many say FSH? You better commit, or I'm gonna commit for you. Testosterone, GnRH. Pardon me? I've got slides. High levels. So level, which one of these is a hypothalamic hormone?
FSH.
Okay. Okay. There's only one hypothalamic hormone. Okay, all right. I'll post this. You don't have to copy the questions.
We have.
Huh? Oh, it came, I posted the wrong call. Oh, it doesn't have the answers, yeah,
No.
okay. All right, what access storage and maturation for sperm site? Prostate gland,
No.
epididymis? Okay. Vas deferens,
No.
penis.
It's an ass day. She's.
All right, which of the following is true about uterine leiomyomas? Most are benign.
Yes.
It's more common in Hispanic or Caucasian women. It's actually more common in African American, those, very, very common, like, very, very common. Light menstrual bleeding is a sign of fibroids. Leiomyomas can be found on the physical, cannot be found on physical exam. Yeah, sometimes if they're big enough, you can feel them. All right. And which of the following is not considered an STI? Okay, very good. All right. Well done. All right, questions from me?
Oh, that's the same. Oh, that's the answer.